Good morning, everybody. My name's Nick Coatsworth. I'm the Health Reform Ambassador at the Australian Patients Association. I'm very grateful to all of you for your time today. We're going to have a webinar on low-value care, the challenges and ways forward. I'd like to just open by acknowledging that I'm coming to you today from Canberra, which is Ngunnawal and Ngambri land, and pay my respects to elders past, present and emerging, and any Indigenous Australians who are joining us today. You know, it reminds us that the concept of low value care and the effect that it has on our healthcare system is sort of shown into stark relief when you think about other problems within our healthcare system, like the gap we have between the health outcomes between Indigenous and non-Indigenous Australians. Today, we're very lucky to be joined by Professor Ian Harris. Ian has been a long-time campaigner to increase understanding and awareness of low-value care in the Australian healthcare system. He's written a number of books, surgery. Is it, Ian? Is it Surgery, the Great Placebo? Is that the title?
Yeah, The Ultimate Placebo.
Surgery, the Ultimate Placebo, and another one recently with Dr. Rochelle Bushbinder co-authored, and that's called Hypocrisy, and that's the one that I'm reading at the moment. And I'd very much commend both those books to you. Kylie Woolcock from the Australian Healthcare and Hospitals Association, the CEO. Kylie, very grateful for your attendance today. And what we're really looking for from both of you is to improve the understanding of the webinar participants and those who are going to watch this on recording on what low value care is. Now, we've got a broad range of participants who are logging on through to from people who are consumers of healthcare, all the way through to people who have very, very detailed policy knowledge. We will, I'm sure, have some interest from some journalists who I've seen pop up online. Thank you for joining us. And so our answers are going to be calibrated all the way from defining low value care right the way through to some of the detailed policy responses. We've got a lot of people online at the moment, which is great. As you hear from Ian and Kylie, please go to the Q&A tab and put your questions there. And my colleague, the CEO of the Australian Patients Association, David Clark, is going to be moderating those questions for us today and aggregating the themes and posing them. So we're going to open up straight away. That's enough from me. I'll be your host today, but we really want to hear from Ian and Kylie. So I'll ask Ian to start off with 10 minutes on what is low value care and why is it important for us to understand and appreciate it. Thanks, Ian.
Okay. I'm just going to be 5 or 10 minutes just giving you a bit of a background. There's a lot of definitions around, high value, low value, and it sounds like a grade of things. I'm going to keep it pretty simple. I'm going to talk about things that don't work. Now, you can call these things low value, but you can also call them no value for a lot of the things that we do. And my area of specialty is surgery. Just as background, I'm an orthopedic surgeon, but I'm also an academic. I'm a researcher who does clinical trials, and I study the effectiveness of surgical interventions. You can refer to these two books that I've written, which explains in a lot more detail the message that I'm going to try and give you in a few minutes here. There is a thing called the 60-30-10 rule, which is fairly well known. There's been lots of studies done in lots of countries, not just Australia, that show that about 60% of what we do in healthcare is helpful, 30% is not helpful, and that could be classed as low value, and 10% is actually harmful. So not only is it not helpful, it actually harms people. And this 60-30-10 rule is quite consistent, even in high income and low income countries. And it's been estimated that low value care in the US alone costs about $250 billion per year. It's well known. People in the community don't always know this, but in the medical community, it's fairly well known. There's Lots of articles written on it. Less is More is a series in the Journal of the American Medical Association. Too Much Medicine is a series in the BMJ. Preventing Overdiagnosis is an annual conference which has been going for many years of international researchers who look at this. Wiser Healthcare is an Australian collaborative looking at this. There's professional collaboratives like Choosing Wisely, which try and decrease the amount of low-value care. And one of the problems, the reasons why we have low-value care is this clinician bias. The doctors who are recommending and performing the procedure overestimate the effectiveness of the procedures that they recommend. We've shown this in research in orthopedics where we've looked at joint replacement. We've interviewed patients and said, how satisfied are you with your joint replacement? And then we've interviewed the surgeons that did those operations and asked them how satisfied are they. And there's always a discrepancy where the surgeons think that the operation went great, but the patients don't necessarily think that. We've shown it in trauma situations, and there's been a systematic review which has shown consistently that healthcare practitioners overestimate the benefits and underestimate the harms of what they do. And some of you think, well, that's natural. Everybody thinks that what they do is a little bit better than it really is. Most drivers think they're above average, that kind of thing. But the problem is the decision-making is often led by the clinicians, and those clinicians are recommending their surgery or whatever the treatment is based on their own perceptions, and those perceptions are wrong. They are biased, and it's been shown over and over again. And the reason why is because when we're assessing the effectiveness of something like a surgical procedure, for example, surgeons tend to look at what's called observational evidence. They tend to just look at their own experience and what other doctors tell them. What we really should be doing when we want to assess effectiveness is using the scientific method. In other words, controlled experiments, because that's actually what tells us whether something's effective or not. Certainly many of these have been done, and famously many of you will know that there's been many studies, and we've published on this looking at knee arthroscopy, showing it to be ineffective, not just low value or a little bit effective, ineffective, no better than not doing the procedure. And this is consistent evidence that's been shown for a long time. It's taken quite a lot of evidence to change practice, but practice can change. And this graph comes from New South Wales, which has shown a steady decline in the rate of knee arthroscopy surgery in response to that evidence. But it doesn't happen overnight, and it takes a lot of pushing. And in fact, there's many areas around the world where the rate is still going up, such as the US. There isn't a whole lot of experimental evidence for what we do. We looked at all of the evidence supporting orthopedics a while back, and we found that about half of what we do has no experimental evidence supporting it. A quarter of what we do does have good evidence, and a quarter of what we do commonly has evidence showing that it doesn't work, and yet we're still doing it commonly. We looked at this in another review, looking at surgery for chronic musculoskeletal pain, and just sort of skipping to the punchline. We found that there's been lots of experimental studies done, randomized trials, these proper scientific experiments. Lots of them are being done, but less than 1% of all that research actually compares doing the procedure to not doing the procedure. In other words, finding out if it works or not. To me, this should be the first study we do. And in fact, in about half of the things we do, that study has never been done. When the studies are done, most of them show that surgery is not effective. And yet these are the most common operations that we do. Knee arthroscopy that I mentioned before was the most common operation in orthopedics in the world, with millions being done every year, and they're still being done. I'll skip forward to that. It's consistent with other reviews. This is a review from the BMJ, which looked at 10 common orthopedic procedures. They found no strong, high-quality evidence supporting most of the things that we do. So why are surgeons doing things that don't work? Often they justify it by saying the patient wants it. I don't think that's a good excuse. They often think, well, they've tried non-operative treatment, so maybe we'll try surgery. even though it doesn't work. And to many doctors, not offering a treatment is often seen as a failure to care. It's kind of like, well, at least I tried something. But in reality, the two main reasons why surgeons still operate is because there's financial incentives and because, and this is a study we did, showing fusion rates in the private and public sectors. And you can see that in the private sector, it's been increasing for 20 years. This is Australian data. Whereas in the public sector, it has not been increasing at all. And that shows a strong financial incentive. That's one. But the other one is surgeons still operate and do things that don't work because they believe that they do work. And this is the problem. This is the clinician bias. And this is what drives it. I'm nearly finished, but please take a look at this slide. This slide is from a study comparing arthroscopic knee surgery to pretend surgery or placebo surgery, where the patients thought they had surgery, but they didn't do anything inside the knee. So there's a blue line and a red line here showing improvement over time. So this is when they had the operation, and this shows that people got better. The problem is that people got better whether they had the procedure or didn't have the procedure, because the blue line and the red line track exactly over the top of each other. This study tells us that doing this procedure equals not doing the procedure, and it tells us that it doesn't work. In clinical practice, when doctors operate, they are only seeing the blue line. They operate on people here, and then they see the people get better. And when they only see the blue line, they commit a logical fallacy called post hoc ergo propter hoc, which means it follows, therefore it is because of. So in summary, the problem statement is that overdiagnosis and overtreatment is rife. It's about 1/3 to 40% of what we do in healthcare. There's system problems driving this, financial incentives, activity measures. Everything we do in healthcare rewards activity, but there's doctor problems as well. There's this natural bias in the community to think that surgery works. And we tend to overestimate the benefit and underestimate the harm, and we're not approaching it scientifically. And the solutions are to reform the systems that incentivize interventions that don't work, but also to reform the doctors. We need to recognize the biases and challenge our current beliefs. And we need to use high quality evidence when it's available. And when it's not, we need to generate that evidence by doing the studies. But currently there's no incentive for us as surgeons to do research to find out if what we do works. We don't need to do that. We can still do it and we'll still get paid for it without that evidence. And that's a big problem. Thanks.
Ian, thank you so much for that. I appreciate how challenging the task I set you to put that all into 10 minutes is. It is an extremely deep and complex area. So I would just make a couple of comments before we throw to Kylie. The first one is, it was remiss of me not to thank our partners, Bupa Insurance, who have supported this webinar through their communications team. So I want to acknowledge Daniel Parsons, December Conway and their team for assisting us today. We're very grateful. Kylie, now you're a pharmacist by background, but you've moved to become one of Australia's leaders in health policy and health reform. I'm very interested to hear what you have to say from the perspective of the Australian Hospitals and Healthcare Association, delving into sort of the policy side of low value care and meeting some of those challenges that Ian so beautifully articulated there. Over to you.
Thanks, Nick. And just to provide some context around who the AHHA is, we're a peak membership body for public healthcare. Our membership comes from the whole public healthcare system, so hospitals, primary healthcare networks, primary and community health services. And so our interest really is not any one part of the system, but how the system comes together, and that's why we focus a lot on what those system enablers are. when we talk low value, it often arises in conversations about a waste of health expenditure. So it really comes from that financial perspective. And as Ian flagged, we see this 60-30-10 sort of proportion of what healthcare expenditure is going towards, and see that there's a lot of opportunity for us to improve. And that improvement really has very broad-ranging benefits. We know that it will improve patient outcomes and experience if we address low-value care. People want health. They don't want healthcare. And if we really hold on to that as our key focus, it's good for the financial sustainability of our system. We don't want to be spending money on things that are not worthwhile. It's good for the healthcare workforce as well. And this is quite a complex area, as Ian raised. It's often we don't have visibility of the outcomes beyond what we're doing in our own environment. And so, once someone is discharged from hospital, for example, their experience in rehabilitation may not be fed back to the clinician. So they may never see the variation in the types of care that we would want them to see. And also there's a lot more interest now on that environmental impact of low value care. So we've seen at the end of last year, we had the launch of our National Health and Climate Strategy, and there's a big focus in there on low value care as well. Doing more uses resources that impact our environment and which impacts climate change, which ultimately affects our health and well-being as well. We've seen, though, and as Nick invited me to talk about what are some of those system enablers that we have, we've seen a lot of focus and a lot of investment in Australia in identifying low value care. And Ian raised some of these. Wiser Healthcare, that's a research collaboration for reducing overdiagnosis and overtreatment. We've got the Safety and Quality Commission that has their Atlas of Healthcare Variation. And this is really about understanding variation in healthcare and using that information that's routinely gathered across the system to show how healthcare varies and raise important questions about why the variation might be occurring, and prompt that investigation into whether that observed variation reflects difference in people's healthcare needs, or whether it is about the choices that are being made about their treatment options, and allow us to then explore, what we need to do about that. Evolve, which was a physician-led initiative to drive high-value, high-quality care, or Choosing Wisely. Both of these are profession-led campaigns, and their aim is for the professions themselves to identify within their own practices what practices are low value. The problem that we've seen, particularly in overseas campaigns that are similar to these, is that professionals tend to focus on those interventions or initiatives that are, infrequent or low impact or are less financially lucrative in their practices. Their challenges with being uncertain about then how do we actually de-implement or adopt certain medical practices. And we really have had limited success in Australia, but also globally, in actually pursuing removing low value care from our system. There are lots of health system levers that we can use, and funding is clearly a critical one. Activity-based funding mechanisms are really important for some, are really useful, for paying for certain types of care, but it's not right for all care. And we really need to be shifting that focus to look at, well, how do we understand the outcomes that funding is achieving, and making sure that that's incentivising the right kind of behaviour. Our system has done certain system enablers in that. We have a health technology assessment review process, and we have that for medicines, we have that for medical services, and we do have an MBS review process. So there's this continuous review of MBS items. We have introduced clinical quality registries for various processes, which again is that importance of identifying the data that will help us to pursue what outcomes are being achieved by interventions, and feeding that back to clinicians so that they can understand it. But again, how widespread that is varies. And what we know is that there is a lot of variation in terms of which healthcare encounters are experiencing more low value care than others. Ian referenced the Australian Care Track study, and it showed, for example, that actually only 13% Alcohol dependence services, for example, are actually in line with clinical guidelines, whereas comparing that to sort of 90% of coronary artery disease. So, but on average, we're seeing only 57% across the 22 conditions that were measured in that study are actually, show adherence to, best practice guidelines. So there's a lot of opportunity to improve what we do, but the challenge is we're identifying it, but we're just not taking it to that next step. Thanks, Nick.
Thanks so much, Kylie. Now we do have questions coming through on the Q&A, which I'll get to in a moment. So please put your questions there, and we will ask them. I am going to open up though with a question around why we, as the Australian Patients Association, particularly had a focus on this in the past month, and that was the Four Corners investigation into spinal stimulators that was aired, I think, about 4 weeks ago now. Very, very critical and important investigative journalism. Ian, I wanted to go to you and ask, can you just talk us through spinal stimulation as a concept so we're all on the same page, but why, in your view, it represents an example of low-value care as a bit of a case study for what's going on here?
So I think it's a classic example of something that appears to work, but it does not work. These devices are implantable devices that involve putting a wire or electrical lead into the spinal cord, and it's attached to a stimulator which triggers an electrical signal. And the idea is that there's a small electrical signal that goes to the nerves, and it somehow provides some kind of feedback or negative feedback and reduces your pain. It's very much a theory. Now, these have been used for decades, and the practitioners that use them often love them, and they say their patients get better, and then they assume that their patients get better because of the stimulators. However, we did a Cochrane review, which is a high-quality systematic review of the experimental studies. So these are studies where all of the patients have a spinal cord stimulator inserted. Half of them, it's not plugged in or switched on or active, and the other half, it works normally. But the patients don't know whether they've got the active one or the inactive one. When you look at studies like that, there is no difference in the improvement between patients who have the active spinal cord stimulator or the inactive spinal cord stimulator. Now, that's a scientific study that says this doesn't work. So it's a classic example of something that appears to work and yet it doesn't. And what we don't take into account when we do those studies is the fact that they cost $50,000 on average to put in. They often get revised. About 1/3 of them need another operation after definitive implantation within 3 years, and they are associated with harms. So it's costing us a fortune, it's causing harm, and it doesn't work. And yet it's something that's very common practice.
Ian, thanks for that summary. There's a question on the line, which it's directed to you, but I'm going to go to Kylie first, and back to you, Ian. So, Kylie, if we are to better define what represents low-value care, both in surgery and other aspects of medicine, who should be the body to define that, given that there is this disagreement with what the evidence says, what clinicians say. At the moment, the MBS seems to be the sort of thing that allows people license to then go ahead and do these things. What's your view on who should define this?
Yeah, I think it is. I mean, given how our health system is structured, it really is something that the whole health system needs to come behind. There are examples where, we need to make it a funding decision, where it is that we just don't pay, but we need to make it something that's consistent across public and private, because we don't want, the experience for a consumer may be being told in public system, we're not funded, this is not being funded, but if you come to my private practice, I can do it there for you. And then it's just placing the burden on the individual. So where there is this evidence where the outcomes just are not there, we need to be really clear that we're just not going to fund that as a system. But there are some other areas, if you sort of think about people, futile care at the end of life, that's something that where a conversation needs to start much earlier in someone's, care journey. Then it's about advanced care planning. So we're seeing different kinds of mechanisms in place for different kinds of low value care, because it isn't just a sort of a hard and fast, let's just fund or not fund.
Ian, there is a concept called data denial, I guess, and it happens a lot in medicine. People will find ways, clinicians will find ways to say, well, the data doesn't apply to my patient, or something's different about this, therefore I'm justified in doing it. How do we manage data denial?
Through education, it's very difficult. There's lots of ways, as Kylie's touched on, that we can try to control or minimise low value care. The way that I push is to try and educate practitioners into their own personal biases, into understanding the evidence generated by scientific studies and how their own observation may actually be wrong. The patients that they see improve may have improved anyway, to get them to consider the options. But other ways of doing it are, simply to not fund things that don't work. That's actually been difficult in the past. Because if the surgeons or the doctors still believe that it works, they'll find a way around it, or they'll push back against it. So that's been quite difficult to do.
Now, just building on that, you're affiliated with the University of Sydney. I'm affiliated with the ANU Medical School. There's enough of us around that are affiliated with medical schools. How is this actually being taught at undergraduate and for the postgraduate medical schools, postgraduate level? Is it getting the exposure it needs?
No. When I did my training, there was almost no training in the scientific method in understanding this kind of thing. Certainly, it's better than it was, but this kind of training is not part of it and of our routine training. And unfortunately, and particularly in surgery, but it applies across the board, we still very much learn on an apprenticeship model. And an apprenticeship model means that I'm just going to go out and do whatever it is that my mentor or my teacher did, because he or she thought it worked, and so I believe them, rather than a more objective, critical appraisal of the available scientific evidence.
Kylie, I've got a thorny policy question for you, which has come from one of our audience members, and you referenced surgeons sort of seeing patients at the time of operation and only a couple of times thereafter. Implicit in that is that, a surgeon's income is derived from performing surgery. Has anyone come up with a good way to pay a surgeon not to operate? And do you have a good way of doing that? And then I'll go to Ian on that question as well.
Funding is a mechanism for driving different behaviours, but it's not the only mechanism in isolation. So it's about, though, putting the right data in the hands of the right person at the right time so that they can make good decisions. And I think that's where our system really has challenged at the moment. While we have lots of silos of data and we don't have good interoperability. So, we're seeing, though, a lot of investment happening. New South Wales with their single health record that's, will enable some of this work. But it doesn't extend beyond the hospital system. So how do we think about pathways of care and putting that information in the right hands so they can see the impacts of the decisions that are being made? It's a big challenge, and it's not one that we're not aware of, but there are lots of and lots of people working on that.
And Ian, perhaps your comments on the sort of financial incentives, which I think we need to frame as, simply this is people's income. This is how they derive it. We're not suggesting any impropriety here. We're simply suggesting, as you did in bold down at the last slide, one of two real drivers that we have to address if we're going to overcome low value care.
Yeah, and it's going to take some hard decisions. But if you look around the world at different health systems, and there are health systems where surgeons are not paid per procedure, they're not paid on a fee-for-service basis, and you see vastly different practice. So if you look at lumbar spine fusion, for example, the highest rate in the world is in the US, where surgeons get paid handsomely to fuse spines. And you see in between the private and public practice in Australia that it's largely a private sector operation because it's not worth doing it in the public sector. And then you look at the UK where doctors are salaried, and you find that the rate of spine fusion there is 5 to 10 times lower than in the US. So you get these huge practice variations based on how surgeons are paid. One alternative is to not have a fee-for-service system where surgeons are paid to operate.
Yes, absolutely. And I think, I think that's going to take a lot of doing. But one of the issues there is the weight of the political influence of practitioners who derive their income from fee-for-service. So, Kylie, just before I get on to some of the other questions, which are now flowing thick and fast, what is your view on how to overcome some of those political difficulties for a minister, say Minister Butler now or Minister Hunt before, of saying, well, yes, it's actually better if we salary our practitioners?
I'm not sure I'm going to respond to that one specifically, but if I sort of respond to some of that funding element of it, is it's not just how we pay the surgeons, but actually how we pay the rest of the healthcare team that sits around that. And that's what we're seeing influencing is. And I used to, see that as a pharmacist, is people would have pain. The funded opportunity for treatment is a pain medication, when really actually some of the more effective treatments would have been perhaps physio or, but people are limited in terms of what sort of options they have. So while ever we silo the way we pay or the way and who we pay and how we restrict that without thinking about the whole patient journey, and I think we see it in mental health as well, again, easy to prescribe a medication when actually other therapies may be more effective. And, we did see some great some announcements, at least in the budget this week. But how do we pay differently? But also, how do we think about the whole healthcare team and what their role is in a patient's well-being? And I think the other area we see that in is social prescribing. So the focus on that of saying there's actually, a lot of other elements of well-being that could improve someone's well-being. That's not just around an individual or siloed intervention.
Thanks, Kylie. Now I'm going to start going through these questions. Now, from Barty, our General Manager at the APA, I'd just like to acknowledge Barty's work for the APA. Thank you. And she's posed a question which I think is important. Accepting that we have an education role to do with our patients about what low-value care is and isn't, but do you think patients would react negatively if options were taken away from them, even if they represented low-value care? And how should we attend to that particular problem of patients feeling as though their options are being constricted?
I don't think so. Well, they shouldn't. If I get patients referred to me saying that they've been told they need an knee arthroscopy and they want a knee arthroscopy. And I explain to them that the procedure doesn't work, and then they don't want it. I don't understand why a patient would want a procedure that's ineffective. So I think that as long as they understand the evidence, they should understand the removal of that treatment option, as you've put it. I mean, to some extent, you could say, well, if somebody wants to pay for it and they want to try it, then they should have the right to. That could certainly be argued, but in the system that we work with, they don't pay for it. We all pay for it. We pay for it in premiums, we pay for it in taxes and Medicare levies and GST and everything else that goes into healthcare. So that's one of the reasons why we should consider this.
Kylie, a question on data collection, or did you want to? I saw you wanting to respond to that.
Yeah, I think building on what Ian said, and we've seen different initiatives around the world, but one in Italy is slow medicine, and I think it's giving people the time to have those conversations to actually understand what it is that their options are and what does that actually mean for their outcomes. And I think as we've sort of moved to more efficient, fast medicine, we do actually miss the opportunity to actually have these conversations with people to understand what their options really are.
We've got a lot to thank the Italians for: slow cooking, slow conversations at dinner, and now slow medicine. I think that's a great idea. Kylie, just from a sort of system perspective, we've got I guess a world-leading orthopedic joint registry, but what are some other examples that you're aware of registries like that, and who should be responsible for creating those registries once a device or procedure or anything makes its way to the Medicare benefits schedule?
I mean, it's a big question, and it's one that has been being reviewed nationally because there are registries that have popped up everywhere. There are a lot of cancer outcome registries. There are lots of, there's the prostate cancer one, there's kidney health ones, there's the palliative care outcomes registry. It's engaging people in using them, and perhaps that's a conversation that patients can have with their clinician is, are they participating in a registry? If there's a registry available, are they participating in it, and what are their outcomes? And, how does that inform the advice that they're providing? I think is some way that could empower people to ask about. I guess one of the challenges is if you start, and this is something that we've had conversations with some of the newer startup outcome registries, is if you become too adamant about how that data is going to be used, that clinicians will just withdraw from using it. So, to what extent can you mandate participation in outcome registries to ensure that data is being collected and can be used for patients to make decisions?
And Ian, from your perspective, how functional do you think that joint registry has been, and do you think it's a replicable model across the surgical subspecialties, including for spinal stimulators, I guess?
Yeah, you've got to be careful. And disclosure, I was a deputy director on the Joint Replacement Registry until recently. It's a very good registry because it's very comprehensive, and it tells us a lot about the comparative effectiveness of different ways of doing a joint replacement or different types of joint replacement. It does not tell us one thing about whether joint replacement is better than not doing a joint replacement. The registry doesn't tell us that. And the call for a registry for spinal cord stimulators is problematic because it will record all of the spinal stimulators put in, and it will record how the patients went afterwards. It will show us the blue line from that graph I showed you where there's a blue line and a red line. It doesn't tell us whether they're effective or not. So a registry is not a clinical trial. It's not a scientific study of effectiveness. It's a record of use.
So I'm going to delve specifically into that then. Given what we know about spinal stimulators now, what signal should the government be sending to Australian clinicians about their use, and how should they send that signal?
They should be applying the same rules to spinal cord stimulators that they apply to any device or procedure that is currently applying for listing or funding from the government. So if you just invented spinal cord stimulators last year and you wanted the government to list them for reimbursement, you would have to satisfy quite a high bar of criteria of scientific studies. And at the moment, they would not satisfy that bar and they would not get funded. The reason they're funded is because they happen to be around when the Medicare medical benefits schedule was created in the mid-1980s. And everything that was being done then was lumped on and funded. Since then, if you want to add something, you've really got to show that it works. But all of the things that have been on there for the last 40 years haven't had to show that level of evidence. So I think that the level of evidence needs to apply to everything that's funded, not just to new things.
Now, Kylie, I'm going to go to you with this one. And we're using stimulators as a case study. I'm happy to continue with that with regard to this question. What do we do? And this is actually been posed to me on a number of occasions in the past month after I made some comments on the Today Show about stimulators. What do we do with the patients with chronic pain when we defund spinal cord stimulators? Should it be redirected towards other healthcare so those patients don't go untreated? And how can we then support and direct patients towards more evidence-based or less harmful interventions in a complex system? You've covered some of it, but just your thoughts on that question.
Yeah, absolutely. I think that's the key, though, isn't it? When we think about low value care, on the flip side, there's high value care. And so when we remove low value care, we need to make sure we're incentivizing high value care. So whatever it is that treatment pathway is, we need to be really clear that, you know, patients will be supported, that it won't be unaffordable. I mean, they were the Medicare principles that we started with way back when, you know, John Deeble was co-creating the scheme with Dick Scotton. So coming back to saying, well, what is effective? How do we treat what matters to patients and achieve the outcomes that they want and fund for those pathways? And so we do need to sort of move away from thinking about, you know, very isolated, activity-based, profession-based, and think about how do we fund and support people to have access to the care that will actually improve their outcomes.
And if I might say, that was just such a beautifully patient-centred way to put it. If there's for low-value care, there's high-value care, and I think that responds to some of the commentary that we're getting in the chat about consumers being concerned about you know, restriction of care. There's actually an alternative which represents good evidence-based practice. Ian, there's a question for both you and me, but I'm going to stay as a moderator and let you answer it, which is, how have you changed your practice? Give us one example of, and maybe not knee arthroscopy, give us another example of how you've changed your practice in response to understanding that something's low value care.
Yeah, I think I'm a good example, if I could say it, because I started practice without an understanding of what we call evidence-based medicine. And I did many operations based on what I was trained to do. Not just knee arthroscopy, but spine fusions, for example. I used to do spine fusions for back pain, a very expensive and potentially harmful operation that is ineffective. But it was only later when I went into academia and I started learning about the science behind medicine that I discovered all of this evidence. It was never shown to me before. And so I stopped doing spine surgery altogether many years ago when I was going along this journey. But there's been many other changes. My practice now is mainly in trauma surgery, and there's so many things that we do that are not necessary. I've completely changed my practice from when I started.
Thanks, Ian, and I'll give a response to the question and lead to the next question, which I'll pose to Kylie. But so I work in an acute medical unit at Canberra Health Services, and I see an incredible amount of overuse of diagnostic imaging that is outside guidelines. And you'll remember Kylie's statistic that in aggregate of 21 clinical issues that had clinical guidelines, only 57% of the time were being followed, and down to 13% in alcohol and other drugs. So, you know, when a patient comes in with respiratory problems, the number of times they are getting a CAT scan to look for clot in the lung when there's a clear alternative diagnosis, it's enough to sort of drive you a little bit more grey, and I think that's there's an interesting point that we might dwell on when I ask Kylie and Ian to summarise towards the end of the webinar. But sometimes I'll teach my junior doctors this, but you do feel as though you're shouting into the wind a little bit against some of these practices. So then, Kylie, a question from Kate Saunder, who I've worked with before. G'day, Kate. What are your thoughts on over-servicing in medical imaging, particularly in public hospital emergency settings where there's incentive to admit or discharge patients, or really, I guess, incentive not to miss anything? How do we manage that?
I think that's a really genuine concern. You know, there is a fear of missing something, and I mean, it comes back to that education piece of really pushing, well, why are we doing how is that going to change the course of the treatment if we do imaging, recognizing it's not a panacea to diagnosis. It is done as part of a whole clinical picture, and we see it in pathology tests as well. I would consider myself a fairly well-informed consumer, and have had the experience myself of a child who's has injured their ankle, and a GP has said, well, we could go send you off for an MRI. And, me being in this space, I said, well, how would that change what we do? And they said it wouldn't. It's not funded by Medicare, but you could go and pay for it privately. And as a parent, you're sort of going, I want to do everything I can to make sure my child's well. But, I'm also sort of thinking, well, I'm not just going to go and pay $300 for an MRI if it's not actually going to change what we do. So there is a level of, that we need to educate clinicians on how they respond, how they understand why things are or aren't funded, and not just shift the burden to the patient, which I saw came up in one of the chats as well. And we, as consumers, we need to sort of understand, well, how do these things change what it is? And I think emergency is probably difficult because consumers are quite stressed at that time. So the onus really is on clinicians to really think through how is this going to change the treatment course that I'd now recommend.
There's, just in that answer there, there's the implicit asymmetry of knowledge between the clinician and the consumer of healthcare, the patient. Ian, how can a patient or their family members actually recognise low-value care, or how can they ask questions? And do you think that shifting that locus a bit towards a bit more patient awareness and literacy is likely to be part of the solution? And if so, how? 4 questions in one, sorry.
One of my solutions, as it were, to these problems is more science. We need to be more science literate. Like I had to educate myself in science, but I've been pushing that amongst practitioners, but I'm also a big proponent of pushing that amongst the general public, that we all need to be a little bit more scientific when we look at things, whether it's evidence around COVID or anything, not just our own personal health. So I think science literacy is very important. As far as what patients can ask or where they should be going or how they can help get better information out of their doctors, a couple of things. First of all, if you're concerned at all, ask for a second opinion. That's actually quite helpful because you'll often find that doctors vary a lot in their recommendations, particularly surgeons. But also just ask the most important question. When an operation is or a treatment is recommended to you, just ask the question, what is the evidence that doing this intervention is better than not doing the intervention or another safer, cheaper alternative? It sounds like almost like a stupid question, but it's the question that needs to be asked. And often when you get asked that question, the doctors will say, well, we don't really have good evidence, or the evidence shows it doesn't work, but I think it does. And you'll get all sorts of strange answers sometimes, but that's what you really want to know. What's the scientific evidence that doing this procedure is better than not doing it?
Kylie, you gave a beautiful example of your own family, and I think everybody on the webinar would have similar sort of examples of that asymmetry. How do we ensure that people are empowered to ask that specific question that Ian just posed then?
Look, I think it's something that we're seeing even come through in the education system now around critical thinking, and I see my children having those, challenging a lot more now than I believe I was taught to. But I also don't think we should put it back on, it shouldn't be an individual's responsibility to do this, and our system needs to better support it, which does mean things like having, sufficient time for clinicians to have those conversations. And it doesn't need to be a lot of extra time. Sometimes it's just that extra minute to stop and answer the questions and give the patient the time to reflect on the options. Our funding system does need to stop paying for things that aren't of value, or at least create that differential to sort of make people think twice about where they take it. But we do need to be careful that we're not pushing burden onto consumers to have to make a choice around what the evidence is. One big problem we do have in the system is that we don't, it's that time for evidence to get into practice. And, I'm not sure what I think the last paper I read, used to be 17 years and now it's 15 years, but still that's a very long time for evidence to get into practice. So what are those system enablers? Funding's one, but clinical decision support tools in our medical records can be another one, and education is critical.
But I'll just press you on the point of funding, and just to sort of be completely bipartisan, this has been every health minister of both political stripes for the past probably 20 years worth of budgets, and including the one that was delivered 2 days ago, is a reinforcement of the MBS fee-for-service model. When you try and look in there for alternative funding models, it's really hard to find. So, what do we need to do with the people who make the decisions to try and shift that? And I recognise it's not going to happen in one budget cycle.
Look, I thought we saw some promising direction when the Independent Hospital Pricing Authority became the Independent Health and Aged Care Pricing Authority. That expanded that consideration of how we fund beyond hospitals to aged and health more broadly. That any consideration, though, in that health sphere has to be at the direction of the minister or the secretary, I believe. So I think there's an opportunity for us to say, well, that's, let's push our politicians to actually go, let's consider how do we fund differently in this space that's considering that whole healthcare pathway, not just hospital in isolation of primary healthcare and community healthcare and preventive healthcare and everything that happens outside of the hospital walls. I think that, having a 10-year plan in that space to say how do we shift our system in some of these areas. But as you said, there are some straightforward examples where we could just stop funding.
Now, there's been a couple of questions from Thomas and Peter. Of course, this is not just surgery, and it's not just about the Medicare benefits schedule. There's a whole host of things outside that we do for our health, like the multi-billion-dollar vitamin industry. There's also, more specifically, medicinal cannabis. I mean, how does this all fit into concepts of low value care, and are we likely, and then specifically for chronic pain, is medicinal cannabis, in your view, low value care? What sort of evidence base do you think that's got for chronic pain?
Yes, it is. Everything that we try, every intervention that we do, whether it's what you've mentioned, vitamins or medical cannabis, is all subject to scientific evidence. The scientific evidence for medical cannabis is very low for chronic pain, and yet it just seems to be flavour of the month, and everybody loves it because it's just a current fad or a fashion. But the evidence supporting it is very weak. And it's the same thing. If vitamin E used to be promoted as an agent to reduce cardiac events. But then it was shown in a scientific study that it didn't do that. It's everything we do can be subjected to a scientific study to find out if it works or not. But quite often we fly off and promote things before that evidence comes in. And to me, that evidence should be the first thing we do before we do it. And some people, just to address one point, some people say, well, it's hard to do scientific studies and it slows down progress. And my answer to that is, if you have a new treatment or something you think works, we should fund it and we should make it available as part of a clinical trial. So you study it as you introduce it, and then we find out if it works or not. Instead of what we do now, which is, I've got a great operation, let's do it. Everybody loves it. And then 20 years later, we find out it never worked in the first place. Why aren't we studying it at the beginning?
Kylie, why aren't we?
Look, I think in some cases we are, and we're actually putting in place systems. So if we think about, medicines for dementia, there are some strict criteria around who gets to access them, but also if you do not see benefit within 6 months, they are to be ceased. There is no further funding for them. And so we have built in these systems of getting an authorization for prescribing medicines, allowing that, enabling that, it will work in some people and not others. And, we will there's value in exploring this, but it's not continued indefinitely. And I think we, certainly in some of these, pain areas where we, it is really challenging to, think about patient perception, taking on board Ian's comment of going, well, we're only measuring what people know and a placebo could be just as good. But how do we actually capture, outcomes of, patient-reported outcomes, clinically reported outcome measures in a consistent way, so we can say, well, if something's not working, let's stop it. Let's not just continue on because that's all someone knows. Or, how do we feed, this real-world evidence back into some of this evidence, into the health technology assessment process, so that we can see what's actually happening in the real world around the outcomes that people are achieving.
Now, we're just coming up on the hour, so I'm actually about to ask you both just to give us a little bit of a summary of what we've discussed, and then we'll sort of close off at about 12, I think. Ian, I just wanted to pose a final question to you, and I'm not going to break any confidence here, but I did have a conversation this morning with a very, very senior decision maker regarding the evidence or lack thereof for one of the budget commitments, and the response was, "Oh well, you can't do a randomized control trial into that particular intervention." Is that just a sort of nihilism around how hard it is to perform randomized control trials? If so, how do we break through? Or are there genuinely some things that are either too complicated or we've gone too far down the track to perform RCTs?
I think that's a very old-fashioned way of thinking, and people have said that throughout history, and they used to say that about surgery. They used to say you can't do randomized trials of surgery because it's too complicated and it's too important. And now we do them all the time, and they've completely changed the way we think about surgery. Of course you can do them. And there's been many examples in the past of proponents of certain interventions saying that we shouldn't do a randomized trial because the effect is so strong that we know that it works. It's very clear that it works. And later on, a trial has been done and shown that it doesn't work. We all think things work, but we need to put them to a scientific test. It doesn't have to be a placebo-controlled trial. It just has to be a trial of the new treatment versus the best previous treatment, or the current standard, or something like that. It just has to be a comparative study, because by comparing one thing to the other, that's the only way you can find out if something is better than the other thing. If you do a single arm study and you say that 50% of your people get better, it means nothing without a comparator, because you don't know if 50% of the people would have gotten better anyway.
Now, I'm going to ask you both to answer this question, starting with Kylie. We are the Australian Patients Association. We want to give, despite all the things that we've covered today, a sort of single parting thought to patients about how they should manage this issue of low-value care in the way that they're interacting with their healthcare providers. Kylie, what message would you love to give the patients who are online?
Well, I think from an individual perspective, it's a really important role. It's your health. So, it's important that you're engaged in those decisions around your health. I think that patients are involved in all kinds of decision-making processes across the system. So again, how do patients come together to be informed to contribute to those processes? And how do we support, as a system, how do we support that too? So I think there are a lot of roles for patients in this space.
Thank you very much. And Ian, your parting thoughts for patients. We're all patients at some time, as are our family members. What should we take away?
I think patients should be demanding the evidence. It's not enough for me or people from Choosing Wisely or whatever professionals saying, we should have better evidence. I think the patients should be doing it. I think they potentially have a much more powerful voice, and they should be asking for the evidence where it's available, and they should be demanding that evidence be generated when it is not available.
Well, on that note, I think they're both great messages to conclude on. I just wanted to thank you both for your time. I know we asked you to do this on fairly short notice, and you've generously given up an hour of your time and the preparation time. Thank you both for your leadership in this space. And you know, you've certainly we've got friends in the Australian Patients as the Australian Patient Association who are prepared to advocate in this sort of way for patients around the country. So we greatly appreciate it. Thank you. This webinar will be available online as a recording. We got 50% engagement of the registrants, which is, I'm told, by December at Bupa is pretty good. And I think I just wanted to also thank Bupa for their facilitation of this. And they're a great partner for the APA, and I guess their support for this idea that we need to shift the dial on low value care. So on behalf of the APA and myself and David Clark, CEO, thank you very much for your attendance, and we'll close the webinar. Thank you.
Thanks.
Thanks.